and get started. My name is Carol Moser. I'm the Executive Director of Greater Columbia Accountable Community of Health. There's an agenda for everybody that we will be following in case you wonder where we're at. We're at the very beginning with the welcome and introductions. Happy New Year. 2019 is hopefully going to be a great year for all of us as we start implementing some of the project areas that we have chosen as an ACH. The two of the project areas are mandatory as required by the Health Facilities bidirectional integration and addressing the opioid crisis. And then we also chose chronic care and transitional care as our two optional projects to pursue. I just want to give a really brief backdrop about why we're going down the PCMH path, and then we will ask everybody to introduce themselves. And then we have some opening comments from Mark and Brian as well. So this is really the very first learning collaborative session. They won't all look like this. Stan has developed a curriculum based off of the 8-change concept that she's going to go through later. But this really is our first opportunity to bring a learning collaborative opportunity together. And we will explain that a little bit more about that as we go on. I do want you to know, though, that this work, our work, has been guided by what we call the Practice Transformation Work Group. And the work group really has helped the GCACH staff go down the path for patient-centered medical homes. They have helped us develop the strategy. They helped select the first cohort of organizations that are going down the PCMH model. And we just wanted to thank them for their leadership, especially Brian Sandoval and Mark Mackay, who have been the co-leaders of this group. As Sam will attest to, leadership is one of those foundational building blocks of any kind of a transition that an organization is going through. So just a foundational principle that you have to have your leadership on board before you can make change happen. And I think that the Practice Transformation Work Group has been instrumental in helping us open those doors to those organizations and getting everybody on board and down the same glide path. And I want to acknowledge the members of the Practice Transformation Work Group. So we have Barbara Mead, Becky Gross is here, Bill Dunwoody, Brian Gibbons, and Sarah's here, I guess, for Brian Sandoval, Dan Ferguson, Ed Thornbrew, Everett Maroon is here, Jorge Rivera, Kat Latay, Dr. Kevin Martin, Leslie Robeson, Lily Gonzalez. Good morning, Lily. How are you? Mark Mackay is on the phone. Dr. Mike Maple. Oh, he's called in. Rhonda Huff, who's the president of Greater Columbia ACH Virtual League, is here. And Ryan Lance from Signal Health. So we chose 17 of your peers to help partake in this work group, and they have helped guide our work, and we can't thank them enough. So you're going to learn a little bit more today about some of the change concepts of PCMH. Becky is going to take you through the contract, what that looks like. What we will be going through the tool. It's still under a bit of revisement after hearing some comments from some of our providers, so we won't address that today, but I will open it up to Brian and Mark and Wes to make any other further comments this morning. Can I go, Brian? Okay.
This is a lot of work.
On the phone, we can hear some clicking and shuffling, but we cannot hear Brian.
Nope, I can't either.
Let's come to the front, Brian.
All right. Basically, what I was saying is there's a lot of information here that is coming at us. So feel free to ask questions, really clarify, help us level set if we're not doing that well. And I think that it's just doing going back to your organizations too and confirming what you're doing, what you need to work on to make sure the right and the left hands are working together. Sometimes, depending upon where you're at in your organization, that can be challenging. So, welcome and thank you for being here, and let's get the work done.
Okay, thanks, Brian.
Yep.
Mark, did you want to say any words of wisdom?
Well, first, Happy New Year to everyone, and thank you for getting us to where we are right now. A lot of preparation in 2018, and now it is real, right? What we've talked about a couple of times. I also thank in advance for the commitment. I'm looking a little bit ahead on the PowerPoint that shows the organization selected and moving forward, and excited about this because this is the right thing to do. We're going to do this, and we need to do this, and so let's get a lot of clarity as stated in regards to the milestones and reporting, and get down the road and demonstrate our success. So thank you.
Wes, did you want to talk about BBT?
I just think that.
Why did you come up so you can be heard?
So I'm Wes Lucky. I'm the deputy director. I think this is really an exciting process. We're really well prepared for success for getting provider organizations through this. I just read a statistic over the weekend from Managed Care magazine, which is a journal that's been put out for decades, and they say now that about 34% of all dollars going through the healthcare system now are through what we call alternative payment models. That's essentially value-based payments, performance, episode-based payments with gain sharing, both upside and downside, population-based risk financing model, full capitation, and more. So the bottom line of that is that fee-for-service is finally going away. It won't entirely be extinguished. There will always be a small amount of that, but from the Medicare, from the commercial, and certainly us from the Medicaid side, we're seeing that transition to those payment models, which puts a lot of responsibility on provider organizations to be ready. And looking at the research, I work at group health. When the group health had head on a care model, there simply isn't a better model that is as comprehensive as that model that takes into consideration all the things that need to happen. Sure, there is no bullet to drive this work. We need to take a comprehensive approach, and we think we have the right recipe.
We are going to actually do a roll call by organization today because part of your milestones is attending Learning Collaborative meetings, and you get credit for that and points for that. And there's a lot of points to be earned, and there's a lot of dollars to be earned this year in practice transformation that's going to take you through some of that revenue sharing model. So we want to make sure that everybody that's attending gets recognized. So we'll just go ahead and do self-introductions around the room. So please state your name and your organization. And then we'll do actually an organizational roll call when we're done with the room introduction. So again, my name is Carol with Greater Columbia GCACH. So I will start.
I think Hunter's Greater Columbia GCACH.
Jenna Shelton, Greater Columbia GCACH.
Lauren Johnson, Greater Columbia GCACH.
Becky Colton, Greater Columbia ACH. Tim Wardell, Greater Columbia ACH.
George, Comprehensive Healthcare.
I go to Strava as a charity.
Sierra Foster.
Thank you, Rose.
Wooded Catholic Clinic.
Sarah Lawrence.
Marshall Disaster. 20 years.
Urban Lead Lord. Class Lord.
This is Dave McKay. I'm with St. Mary Medical Center, actually with Providence Medical Group.
We will get to the telephone in just a minute. You guys are going to have to speak up so that they know you're talking. So, thank you, Dr. Gonzalez. Thank you, Nina.
Pioneer Kilo, Greater Columbia.
Rachel Cash, Greater Columbia. So, can you do the roll call, Lauren? Or I would just go down and see if there's anybody here from Yakima, Astria.
Okay. Yakima, Astria. Anyone?
Yakima, Austria. We have Joe Ketterer with Astrea Health is on the line with me here.
Okay, Astrea Sunnyside.
Brian Gibbons and Christine Parker are on the phone.
Astrea Toppenish.
Again, Astrea, just us here.
Okay. Catholic Charities.
This is Chris Villeneuve.
GCACH. Chaz.
Hi, this is Lindsay Root Bar with Chaz.
Columbia County Health System. Community Health of Central Washington.
Yeah, this is Mike Maple, CEO at CHCW, and I have in the room with me Paul Cashmitter, CFO, Jody Bogus, Clinic Manager at Yakima Pediatrics, Millard McQuaid, COO, Catherine McDaniel, Population Health Manager, and Brigitta Foti-Landstrom, CQO.
Hi, and also Stacey George is on the phone.
You're going to start with the video first.
What was that last name? I'm sorry.
Stacey George?
Brigitta Landstrom. Stacey George is attending on a separate phone, so.
Okay, great. Thank you. Comprehensive.
Yeah, it's Rick George.
Ted Thornbrook.
Garfield County Hospital.
Yes, Julie Leonard, I'm the CEO. I have Marcia Badens, our care coordinator, and Jake Keener, our CNO.
Catholic.
Randy Hartman, Director of Primary Care.
This is Mark Wackeye, and I'm with Providence, which includes Catholic and St. Mary, so thank you.
Kittitas Valley Healthcare.
This is Mandy Olson from Kittitas Valley Healthcare.
This is Julie Peterson from Kittitas.
Lord.
Mark Gregson, the interim CEO.
Dana Otis.
Did someone just log in from Columbia County?
Yeah, this is Shane McGuire, CEO.
Did someone else just log in from CDHA?
Yes, Haley Middleton, and then Dulcie will be adding.
I'm already on. This is Dulcie.
Oh, perfect.
Thank you. Memorial Physician.
Chelsea Ward, Finance.
Police Medical.
And Ryan Lance can represent them as well.
This is Teresa Quaid from Police Medical.
Hi, this is TJ and Teresa Clay from Police Medical.
Proctor Memorial.
This is Tim Cooper, CFO.
And Alana Pumphrey, Director of Clinic Operations.
This is Sue Cheddar from Prosser Memorial.
Providence. I know Mark on the line. Is there anyone else from Providence on the line?
Yeah, this is Dave McKay, Director of Operations for the medical group in Walla Walla.
Is there anyone on the line from Pullman Regional?
This is Jeannie Eiler, the Chief Clinical Officer.
Debbie Heistman, Quality Director from Pullman.
Bonnie, Behavioral Health.
This is Cicely Zorns, Executive Director, and Danica Glynn, Clinical Director.
The Health Center. Oh, there's several from Tri-City Health. Yakima Neighborhood Health Services.
Hi, this is Rhonda, and I'm with the group. I'm going to have each of them introduce themselves.
Chris Newman, Medical Assistant Supervisor and EHR Lead Trainer.
Lori Jones, Director of Behavioral Health Services. Diane Campos, Care Coordination Supervisor.
Anita Manoyan, CEO.
Lorraine Rising, CFO. Michelle Sullivan, Quality Improvement Director.
And Lisa Hefner, Nursing Director.
That's it.
Yakima Valley Farm Workers.
Hi, Sandra's on the line. This is Melissa Park, Director of Healthcare Outcomes.
I'll try to get over there before 5. Okay, wonderful.
Is there anyone else on the line that we?
Okay, you too. Thanks, Deb. Bye-bye.
Yeah, Tom Adams from Chaplaincy Healthcare in Tri-Cities. I'm not on your roll call.
Morning, Tom.
This is Dan Ferguson with the Allied Health Center of Excellence at Yakima Valley College.
Thank you, Dan.
Morning.
Keith Monosky. Sorry, Keith Monosky at Pacific Northwest.
Anybody else that hasn't called in yet? Well, I say we're about 1,000. I think we have 100% participation from all of our provider organizations and our practice work groups. We are just doing one really quick item of business because it is a combined meeting with the PTW and the Learning Collaborative, and that is to, I need a motion to pass the minutes of our last PTW. I would entertain a motion from any of the PTW members. Thank you, Kevin. And Bill, second. Okay. All those in favor of passing the minutes of our last PTW meeting, say aye.
Aye. Aye.
Any opposed? Okay, that little bit of business is over. I would like now to take the opportunity to introduce Becky Cohn to all of you. Becky is our Director of Finance and Contracts. She's been very, very busy getting those contracts out to all of you, as have our practice navigators, who I think have had kickoff meetings with all of the organizations except one. And so we have been out and about, and it is our strongest desire to be of the utmost service to all of you as we move down this path of practice transformation and PCMH. So Becky is going to explain about the contract, hopefully answer any questions that you might have so that we don't have to answer them 150 times. We only have to answer them a couple of times. Yes,
Can I make a comment on the phone? Sure. I muted everyone on the phone so that there's no feedback. So if you would like to talk or have a comment, you'll have to unmute yourself.
Thank you, Lauren. Good idea. And so, Becky, I will let you take it away and take us through the contracts, including the definitions of a provider. Okay. Okay. Great. Thank you. Thanks, Carol.
Thank you all. Welcome. Happy New Year. Most of you received this contract in your email box while you were probably on vacation for the holidays. So I don't know if you've had a chance to read it or not. Some of you have. I know we've actually got 2 back signed, so that's awesome. We've gotten a lot of questions. Lauren's got a lot of questions, so Carol thought it'd be a great idea to kind of run through it. I'm not going to get into the legal stuff that bores everybody, but I'm going to do some of the high-level things and answer some questions I've already received. So we're going to start at the beginning. The very first paragraph is kind of some legal jargon, but it also goes into some of the definitions that Carol was just talking about. Anytime in the contract that we talk about agreement, we're talking about the entire contract, page 1 to, what is this, page 30. And then when we talk about GCACH, of course, that's Greater Columbia. And the important one I wanted to point out is when we talk about provider, we're talking about you. We're talking about your whole entity, your whole company. So for Lord Health LLC, or hospital, LLC, for example. So we're not talking about a physician. We're not talking about an individual person that's all the improvement. We're talking about all of you. So in the contract that you receive, it has your hospital or your clinic or your provider in that line. And then the other thing I wanted to point out is next to it, I just wrote as a placeholder a Washington Professional Service Corporation. If you're an LLC, if you're a nonprofit, whatever, we will change that to match what is accurate. And I have already changed that on a couple that have asked me about that. So down into the recitals, A just talks about who GCACH is, that we're a nonprofit. C, I wanted to point out in the first line the purpose of this agreement, which a lot of you know, but I wanted to just read the first sentence. So the purpose of this agreement is to incent providers and their clinics, which is important, we'll get to that later about who the clinics are, owned or managed by the provider, chosen by the provider. And I wanted to point that out because I want to make sure everybody understands that the practice navigators didn't choose your clinics, you chose your clinics. And the clinics are being incentivized also with this money. So it's important that we understand that. But when we get into the payment section later, we're going to talk about that GCACH is paying you as the provider, and you're contractually obligated to funnel the money down to your clinics that I listed in the agreement. So I just wanted to talk about that more a little bit later. On down to section 1, a period of performance and termination. I'm not going to talk about this a lot because a lot of this is just legal fun that your lawyers will read and talk to you about later. But the one thing I did want to point out in here is the actual completion date, which is January 15, 2020. I've gotten a lot of questions about this just being a one-year agreement. Yes, it is just a one-year agreement. What happens year 2 is unknown to us right now, and we'll come across that bridge when we get closer. And the reason that it's January 15th is because there's one last reporting that's due at that time, which Sam will talk about later. Okay, on to payment, the fun section. Okay, so the payment section, the sentence I really wanted to point out was at the end here where it talks about the GCACH shall pay for the provider for its achievements and the achievements of its clinics, which we just talked about, no more than 30 days after GCACH and the Director of Practice Transformation, which is Sam, is satisfied that the provider and its clinics have completed each milestone for each quarter and achieved the full point value. And I know that's a big mouthful. There's a lot of steps in there, and Sam's going to go through that later. And then the other important one that I get questions about a lot is that this money is not federal money. So I made sure to put a paragraph in there that talks about that because I get asked that a lot. So that's important. Section 3, the allowable cost. Those of you that have contracted with us before, that are BHO providers, you've seen this before. There is an exhibit in the contract, Exhibit B, that has, or excuse me, Exhibit C, that is a list of the expenses that we won't pay for. And it's not anything shocking, it's alcohol. Go on and drink, and they're not going to pay for your drinks or anything. So that is listed as Exhibit C, and most of you have seen it before. So, sorry, I know. So I wanted to point that out, and then this first sentence also talks about the expenditures that you do use for the purpose of this contract need to be put onto the PCMH budget template, which is Exhibit B in this contract. And again, those of you that have contracted with us before have seen it. It's not new. We didn't change it. We used the identical budget from the BHO contract. Section 4. the responsibilities of the provider. I'm not going to read all of them, but I would encourage you to read all of them. They're important. It talks about what we are expecting of you, and then Section 5 talks about what is expected of GCACH during this whole process. But I wanted to point out the first sentence, the responsibility of the provider, talks about that the provider shall register in the Washington Financial Executive Portal, which congratulations, most of you are, but there are still quite a few who are not. But we'll get there. We're going to get there, because that's how you're going to get paid, and that's the important piece, right? So the end of Section 4 also has a sentence about that the provider shall report its milestones by the way of a reporting platform, which I don't know if we're going to talk about that or not.
We can come back to that.
Okay, we'll come back to that. So that's an important piece also, and I think Sam's going to go into that, which talks about the milestone reporting schedule too. We're going to skip on to Section 7, which talks about insurance. Again, this language was in the BHO contract, nothing new. We just want to see that you have insurance coverage of $1 million, which is, I'm sure you all have more contact. So I just need an insurance certificate to put in your file. No big one on that one. I'm not going to read through the indemnity and privacy. Again, those are all legal fun stuff that I'm sure your lawyers will cover with you. So I'll skip to Section 14. This talks about any notification, any communication that needs to come through regarding this contract needs to come through me. And then I need to know who on your side am I communicating with, so that if I have something that I need to get from you, I know who to go to. And same for you, if you need something from us, you know who to go to. So that part section is important that we get that filled out. Am I moving too fast? Is there any questions yet? No. Good. So we are going to go to the signature page, the last page. Yes. So when I sent an email with the contract to everybody, I said that I would send this document to you through DocuSign once you're ready to sign, once your lawyers have reviewed it and you guys have reviewed it. And so I have accepted a wet signature from someone, but I would prefer that we do this through DocuSign. So once you're ready, just let me know and I'll send it. So I want to send if there's any changes, I want to make sure we send the copy of it. So the very first exhibit in the contract is the Transformation Incentive Allocation Weights and Values. And this one is a sample. The one that came with your contract that I sent you has your clinic names and addresses and the title up there. And for this sample is for two clinics. Two clinics. Two organizations. So we have some that are just the hospitals, no clinics, and so their dollars are different. We have a few providers that have the hospital and two clinics, so it's split into three. So what you're seeing, what you're seeing with this, with this money is this is one that's been split into two because it's a two clinic contract. So I just wanted to show this to you as a sample. You all have your actual ones with your clinics named on them in your contract that I sent you. And if you see any mistakes or have any questions about anything in this agreement, please let me know. I am fallible and I did a lot of contracts, and so there's that chance. Yes, Carol?
So you might mention that we've been working with the ability of our revenue policy for us, and he thought it would be very helpful for the practices to have kind of a cash flow quarterly, so you can see on a quarterly basis what we expect to see all of the milestones. So we just wanted to acknowledge that this is some of the cash flow model that would enable your practices to understand how
That's right. Thanks, Carol. So the other thing I wanted to point out, and a question I've gotten already, is when does the quarter end? So I didn't put hard end dates on the quarters. Of course, March 31st is the end of the first quarter of the year, and we So what Sam and I talked about was we don't want you to feel like you have this hard deadline. We want you to feel like you're making the achievements of the first quarter to better your practice and to achieve the goals that we're trying to reach here. So we didn't want you to feel like you have this burning deadline with you. So anytime during the first quarter that you finish any of those things, we'll send you a check. So those of you who are in the portal and already know this, it's every 2 weeks is our payment cadence, and it gets sent through ACH to your bank account that you registered in the portal.
I have a question.
Yes.
So, just taking that 2A, the risk stratification piece, and it's portioned out exactly the same across those quarters. But there's a scoring tool for that.
Yes.
You would expect that organizations will become more and more sophisticated and have the system. So we won't be as good in the first quarter as we will in the fourth quarter.
That's possible.
So how does your scoring work in relation to that?
I think Sam is going to talk about that later. That's a good question, because it is complicated. It's pointing to its milestones. It is very complicated. So Sam's going to go through that. Yes, Barbara?
Thank you. I'm assuming that organizations that have more than one site identified, like more than three, that means we have 3 different budgets. Is that correct?
Yes. Yes. So I chose to show you guys this one because most of you have 2 clinics. You're right, Lourdes is a little bit different. Chad's Health is very different. So some of you are different. Some of you fall into this model. Is there any other questions on this? I think we'll move on. I see you all glazing over. I know contracts are super fun. The next exhibit in the contract I've already talked about is the budget template, which again you've all seen. The BHOs have all seen. Any of you that are new to this, we're happy to explain it to you. It's pretty basic. It's the first box is kind of your planned use of your funding, and the second box is your actuals of what was actually done. So if you have questions on it, we're happy to answer that.
We have the existing building electronic record system. What do we do for that line?
You know, in the completion of like one panel, and then I think we do it one or any other module or whatever, like publication.
Okay, so the question in the room, in case on the phone you guys didn't hear, is the first line item on that budget is new billing or electronic health record system. And if you already have that and you don't need money for it, then just don't fill that box out. Okay. So Exhibit C, I
have one more question.
Oh, yes.
So it's a little challenging to figure out the exact dollar amounts for some of these issues.
Yeah. Yes.
So what happens is, as long as we're allocating the money underneath, not using the money inappropriately, when we finalize the budget, if it's significantly more under, say, technical assistance, that's no big deal because we couldn't anticipate how much technical assistance we would need. So we're basically just throwing numbers in here as best we can on January 4th to do that.
Yes.
There's a part of this that asks if, which Becky's got to go into, if the actual budget differs from the preliminary budget by more than 10%. We just want an explanation, and it's not line item by line item, it's by the total.
Okay.
So you're not being penalized, we just wanted understanding, you had a plan changed based on that.
Exactly. We just want to know basically what you're doing, not going to Disneyland.
And this is a combined budget, correct?
Yeah.
This is not individually per clinic, this is total.
Individual. It's individual per clinic.
Okay.
Yeah.
So we need 2 of these, right? We have 2.
Yes.
Or 3, like 3 or.
Yes. Yes, thank you. That's a good question. I don't know if anybody on the phone heard that. The question was, do you need a budget for each clinic? And the answer is yes. Okay. So Exhibit C, again, I've already talked about this. This is the non-allowable expenses. And I'm not going to read through it. You guys can read through it. But we took this off of the federal guidelines. So not anything that we've made up, but it's pretty standard. Kelly, do you want to?
Well, I just wanted to, we have had several questions about capital expenditures for general purposes. So there is an rearrangement of office facilities that you might have to use in order to get a bidirectional integration for your teaching client care model. We recognize that, and so some of that would be allowable under this category.
Yeah, really what that capital project is talking about is like building a brand new office building. We don't want to fund that. But we understand if you need to do some reorging inside, some knocking down some walls, building some new walls, getting some new cubes, whatever, that's okay. And again, like Carol said, we have with the BHO contracts, we did take it on a case-by-case basis and talk to the provider individually about their needs. So we're not trying to be restrictive. We're just trying to be good stewards of the health care authority's money.
Yeah, Barbara said you wanted to cover expenditures. What about leasing?
Do you want to talk about that, girl?
Like in leasing an office, leasing a new space for provider space.
As long as it helps fulfill the goal of the project service. Great, thank you.
I have a question here from Community Health Center Washington on the budget. This I would assume is to be an annual budget of our program and what it's going to take to implement this practice transformation, which may or may not exceed the funding that is here on A1 and A2, correct?
Yes. There's at the end of the year 2020, you'll have to do an actual budget, and if there's a difference of 10%, whether it's above or beyond, then we'll have to be able to come in and do an evaluation on that, and look at where those expenditures that might be off, that we can assist with that. But truly, I don't think that you're going to have a problem with being able to utilize the money, because a lot of these efforts are already implemented in a lot of the facilities, and it's really being able to allocate those dollars to funds that are already being associated with these different milestones.
Okay, I get it. Thank you.
You're welcome. Okay, so Exhibit D, I'm going to skip over because Sam and her team are going to talk about that in detail. So the last one is Exhibit E, and it's just some definitions to kind of make sure that we're all on the same page with what we're talking about. I don't think there's anything in here that is anything that you guys haven't heard before or a surprise to you, so I'm not going to go through it, but if you have questions about it, just let me know. So that's all I had.
I have one more question.
Yeah.
So we have 3 sites that are not defined under this agreement, 2 sites are. So in the creation of a new structure, there's a cost associated with that. You're expecting that if it costs $100,000 to do that activity, that we would parse that out proportional to those sites.
Yes.
Proportional by patient population?
No.
Proportional by what?
Proportional by what that effort. So if you're, for example, if you have 2 case managers and you're going to look at your chronic disease management, and that case management is associated only with that clinic, then those dollars would be allocated to the
Sure. Right. But if you were to create a risk stratification tool that benefits the entire organization, then the portioning of that allocation would be what?
It would be based upon your risk stratification of how many dollars or time. It would be really per entity of how you want to look at that. Do you want to look at your Medicaid population for each one of those clinics and allocate it out like that, or do you want to look at your patient population and which ones are at highest risk and where those dollars particularly probably go to that one clinic?
There's several ways you can think about
Yes,
it.
exactly.
And it's our decision on how we do that.
Yeah.
Okay.
Okay. Great. Well, I didn't have anything else. I think most of you know how to get a hold of me, but if you don't, I have some business cards up here, and I'd be happy to help you.
I'm going to have Jenna and Martine go over the milestones just briefly, an overview about that, and then I'd like to do a crosswalk and see the budget and how that reporting would look like to receive those dollars associated with each milestone after they done.
Hello, everyone. Happy New Year. So most of you guys know us for the Practice Transformation Navigators. We've been to almost all your guys' locations. I met each one of you. So now we're going to be kind of going over the milestone reporting schedule of what the cadence is for each milestone, terms and conditions, and what type of reporting there needs to be for each milestone. There's in the toolkit, once you guys get it, there'll be a key up on second or third page that will explain you see on there X's, pound numbers, and N, which means selection data or narrative for the milestones. Yes.
We should fill out the toolkit.
A qualified provider meaning that doesn't have to be a physician, somebody, a quality director can fill it out, somebody that's kind of part of the QI team that knows what, the work that needs to go into each milestone. So it's not necessarily a provider meaning a physician.
Ideally, it would be the QI project team that we're putting into place in each of these entities to make sure that the work is being done and monitored.
So something I want to point out really quickly before we get into the detail of all this, like Wes and Carol mentioned before we started, is that we do need a comprehensive approach to practice transformation, and this is just kind of a very high-level summary of our attempts of what we think the best comprehensive approach is. And also a lot of this is attached to the toolkit that Carol mentioned before that is under, yet again, more revisions. We're trying to make sure that that's the best that it can be before we present the final version to y'all. I think everybody got a draft version of that, so it's mostly going to look the same, but a lot of this work is explained further in detail in the toolkit that is still under revision.
So if you guys, on your worksheet, if you guys look at 1A1, which is the first milestone, and that's the budget, on there you guys will see the, if you guys run across, you guys will see Q1, which the date for that budget would be February 15th of 2019. That's when it would be due, and it would just be a selection and data for that reporting. And then for 1A2, another part of milestone 1 is the reconciled budget, which that would be Q4. And that's, again, reporting method, selection, and data for that part. And the terms and conditions list each part that needs to be reported for that milestone. And then if you guys look at 2A1, 2A2, 2A3, 2B1, 2B2, that's a long section. That's a lot of reporting, but some of the reporting on here is very simple. It's just selecting, we do this. For the selection data, you'll have to enter some numbers. This is the number of patients that we're risk stratifying, the numerator, denominator, and then adding some narrative, as to how you guys are applying, for example, your risk stratification methodology. What is your risk stratification methodology? Do some explanation on that.
So we feel like 2 is kind of like the meat and potatoes of this reporting. It's a lot, like Martine said. So we just want to take opportunity to maybe pause for questions on 2 right now. April.
So my understanding is that impediment is appropriate to the applicable to the clinic, but not to the hospital. So if I'm looking at this exhibit, how would I know that?
So that, you wouldn't know that from just looking at this exhibit. There's also another attachment that comes with the toolkit that explains specifically for hospitals. It has a whole section for hospitals, and some of the stuff that applies to the clinics is blank in the hospitals for that very reason, because you don't impanel patients on the hospital side.
And the Practice Transformation Navigators, if there's any questions on that, we're open to that and walk you guys through the whole process as well.
Can you talk a little bit more about what impediment is like?
Yeah. So this is a question we've had come up several times at our board meeting. We've had this question, and it's a great question. What does that look like? So for us, when we say empanelment, we give definitions in the toolkit on the second or third page in there, and it just says that empaneling is assigning a patient to a primary care provider. So for a behavioral health organization, if you have CDPs, LICSWs, what have you, you would assign that patient. So if I was a patient and my CDP was Mrs. So-and-so, I would be assigned to Mrs. So-and-so. I know it's a terrible name example, but you get what I'm saying.
So, but it also talks about a team and a team approach and care team approach.
Yes.
So my assumption based on that was that we have lots of people who are assigned to one person. That's not an issue when people are assigned to one person. But many of our people are not assigned to a team.
Yes.
So what is the definition around that?
Gotcha. We put that in there as kind of as a way to make sure we're covering the whole spectrum of what a practice might already look like. So we know some organizations, it's just you're assigned to a primary care provider. That primary care provider might work with a specific MA or a specific registered dietitian or whatever. But we also know that there's places like Community Health of Central Washington where they have teams. They're already set up, blue team, red team, yellow team, whatever their colors might be. So we didn't want to say assign them to a specific PCP, and those people that have a team think, oh gosh, now I need to, in order to get funding, take away my team aspect and have a PCP, a single person. But we also want to allocate for that other side where people who have a PCP only assigned that way, that they can still function within that whole empanelment piece of section 2. That makes sense?
Some of it does. Part of it that doesn't make sense is, are we needing to move toward an all team-based approach? Because in some ways, that's what integration is about, team-based care. And so I was making the assumption that we have lots of people who have an individual person. We need to start thinking about our work in a different way, more like neighborhood health in terms of team-based care. Are you going to be evaluating us on whether or not we're moving in that direction?
This year, no. That might be something that we look at as a deliverable and a thing in year 2. I know Becky mentioned that prior, like we're coming up to year 2 and we're going to, cross that bridge when we get to it. For this year, no, because we anticipate that practice transformation is going to be a 3-4 year endeavor. And so we know that we're going to have to scale up some of these. We can't start with perfection because everybody.
Rick, just to add though, on an additional opportunity for the toolkit, in the intern clinic, that is one of the options of team-based care.
So Jen, I have a question for you, the empanelment question. Can a patient be empaneled to both behavioral health provider and to a primary care provider?
You can. If your system allows for that, I know that's something we've been working with an organization on, is making sure, or trying to see if we can put that in like a patient's profile, that they mainly see their primary care physician, this person, but their main behavioral health person is this provider.
So I'm thinking in a situation where they're receiving behavioral health services comprehensive, but they're receiving their primary care, perhaps at neighborhood health, can they be empaneled in both those organizations?
I am not sure. I believe so.
For primary care at neighborhood.
Well, and I would argue that because we both have the agenda, neighborhood health is in the mix, we both have to empanel.
That is true.
And so the answer should be yes. They have to be on 2 panels, right?
It should be.
I mean, this model is patient-centered, but we also is primary care center. Ultimately, there has to be some accountability to a primary care provider of one type or another.
Rhonda's on the phone. She can actually answer what their current pathology is to that.
Actually,
Rhonda, do you?
I have a related question, and it's on 2B1. Because our model, the 2B1 says that choose one evidence-based model of care, and our model is actually, we work about 4 different evidence-based models of care, one being the one you're talking about, or that Rick is alluding to, where it's reverse bidirectional, where we're in their setting, and I think he's right, is that I think there are, in that environment, I think there are two providers, 2 identified panel providers. But in our model here, at our other clinics, depending on what the patient's needs are, we may use a collaborative care model, or we're using a co-location model, or we're using the warm handoff model. So the idea that the statement reads to choose one evidence-based model really isn't a best practice, at least not for us. And so I'm wondering if there's flexibility there to say, because we actually have a matrix that Lori developed that shows which model works best for which group of patients. And so I kind of have an issue that we're asked to choose just one model.
Rhonda, so that's an excellent question. If you look across on that section where it says choose one model, right to the left of that is selected a reporting method is in for narrative. And so we left that as like an open box on the toolkit where you could type that in, like we use 4 models and we're using all 3 of these. So that's why we have some narrative sections, because in some of our selection where we think is pretty straightforward, there might be a case like YNHS and comprehensive where you do more. So we left a section for that. Does that answer your question?
Okay. Yes, it does. Thank you.
I add about the main goal is to get bidirectional integration. And let's not lose sight of the bigger picture, how you get there, all the ACs are doing a little bit differently. We just want to know that you're making attempts to get bidirectional integration.
Right. Brian, how does these map to the PCMH requirements, correct?
Yep.
So all we're really needing to do is look at the PCMH requirements and get the application.
And that's also what we can help with as well.
Okay, so I'm just making sure there's no changes around entitlement, time frame, things like that are specific to GCACH.
So we're using the PCMH as the model for
And I
that.
think that's exactly.
I think the only thing outside of that is the map, and opioids, it's a little bit different than the PCMH model, but everything else is consistent with the PCMH.
And that's to address the specific program area, project opioids, which we're required to do. Okay. But, you guys have talked about that.
And within the toolkit too, there's an explanation, there's the intent of, each milestone, there's an explanation. This is why we want you to panel patients. This is why we want you guys to reach bidirectional integration. There's resources in the toolkit if there's any questions like, hey, what are some additional resources? There's some resources in there that are listed that you guys have access to. And then there's a section that explains the reporting, how you guys should report, and the type of reporting. They'll have the same reporting quarters and then the reporting method for each section that you guys would have to report.
In addition to billing.
Yeah.
So in terms of reporting, we can talk a little bit about this right now. So in terms of reporting, ultimately what we want to do is put together what we're calling a platform or a portal where providers can go in and enter in their reporting requirements to meet the milestone deliverables. It's definitely our goal. We're trying to expedite that process right now. In the interim, perhaps for the first quarter, there may be a paper-driven or a file-driven process that might involve Word or Excel, just to make sure that the organizations meet those requirements and get paid according to the cadence that's outlined in the contract. So we're working on that. CSI Solutions is a vendor that we're working to deliver that. Again, because of some timing issues, the Practice Transformation Navigator, Sam, may come to you and say, for right now, here's a workbook that you can fill out to show that you're meeting these deliverables. We put together this workbook. It's still a very long document, but I would just caution everybody, when you look at it, you might see a table that goes on for a page and a half, but all it is a check mark by one box. So ultimately, when that gets in the portal, that long table rolls up into one drop down. Any questions about that? Do you have anything else to say about that?
And then for some of the milestones, there's options, like we mentioned earlier with 2B2. But for, which am I thinking about? For 4A1, it's either a monthly survey, and that's they'll give you options for either a monthly survey, a monthly survey and a PFAC, or a PFAC. A quarterly. And then a semi-annual survey and PFAC together. So there's your practice plan. So it's not that we're asking you to do the PFAC and the survey month semi-annually when some practices are not there. They're just getting started, so that's why they'll give you some options as to what to where to show where your organization is for practice transformation. Patient Family Advisory Committee.
Do you have any questions on that part?
And then the reporting, you guys will see all of the milestones. The reporting quarters might be different. There might be 1 quarter, all 4 quarters, 2 quarters, and then the reporting kind of mixes again, either all 3 collection data or narrative or just 1 type of reporting for some of the milestones.
Questions? The question that's going to come into play would be for organizations that have multiple clinics and how this plays out and what the requirements are across clinic sites. If you've got the patient family community about right now, like aged approach. You see what I'm saying? Starting to think about transformation, and you've got multiple sites. How do we take into account that that's going to require a lift across multiple sites? So, any insight into that?
Each entity is different, even within your own organization. So if you want to have surveys at one site, and you do your quarterly feedback meetings at another site that you work to implement, and that's perfectly fine. We just wanted to implement them, at least giving out the surveys at one site, or have whatever your goal is. If you can integrate those patient information into what you're trying to communicate, that you're making efforts for better transformation of care or better care to the patient, better informed care, then definitely that's where there's other narrative portions in there that we should.
Our system, hospital and clinics are combined. They've developed a feedback for the system, which I think is inadequate for the purpose of this. You need to have a feedback that is individually clinic-based, because each clinic has different concerns with issues. And if you have one that's at the hospital, you'll be addressing concentrating on hospital issues, not concerned with clinic issues. You really need to focus on individual organization, not their organization. So that's our feedback.
That's a good observation, Bill. If you have a rural clinic as one site and then an urban clinic as another site, obviously you're dealing with different populations in terms of what their needs are, perhaps their ethnicity, other things that fit into the mix. So having something.
Hi, I'm sorry, on the phone, we can't hear anything that's being said right now.
So, Bill Dunwoody just spoke from Cadillac outlining what their work is, and I just highlighted that it's important to think about the PFAC or the survey at the site level, because, for example, if one site is in a rural location and another site is in an urban location, you're going to have different mixes of patients. And so responding to those individual groups individually is most beneficial for the practice.
And I also want to add, Bill is correct, when the PCMH standards is that it has to be at the site level.
So we can take a step back and go back to milestone 3, because we jumped to 4. And so milestone 3 is all about 24/7 access by patients. So if you look across, you can see that the reporting is quarterly, and it varies by reporting. So the first one attests that patients have 24/7 access to a care team practitioner who has real-time access to the EHR. All this is saying is that you have an on-call provider who can pull up your EHR if needed outside of the office, basically. Enhanced access by at least one opportunity of care provided outside of office visits, meaning outside of the office visit if it's telehealth or something along those lines, just care outside of that.
Patient portal,
messages, anything like that. Staff time spent on care provided outside of office visits and commitment to timely responses. Those are just data-driven. We just want to know how much time did your staff actually spend responding to patient messages on the patient portal on a Saturday.
And that's an estimate.
Yes, thank you. It's an estimate. So if you don't get those numbers exactly, you can estimate that.
And then, we'll jump to 482 since we want to report.
Yeah.
So, I've been trying to figure this out a little bit. So we have crisis services. And crisis provides what I would consider a narrow scope of service. The expectation would be what in terms of that? I mean, you could say it meets the standard. It does meet the standard.
By definition of having access.
They have access to electronic health records. They can respond to a situation.
And the timely response would be the requirements of us.
Right, which will, yeah. Okay, I'll leave it at that.
482, patient-centered interactions. It's shared decision-making, support patients, and engage and form effective partners in their own health. And if you look at the reporting, it's quarterly, and both of them are selection and narrative. And it's identify and implement shared decision-making tools or aids in at least two to five health conditions, decisions or tests, make the decision aid available to the appropriate patient, and generate metrics for the proportion of patients who receive that decision aid. So basically, if there's a condition, say diabetes, this many patients have diabetes. Out of those patients, this many receive a decision aid. Basically, that's what we're asking for. And provide quarterly accounts of patients receiving the decision aids and show growth in the use of using graphs or around charts. So basically, kind of providing those decision aids to other conditions as well. So not just the first ones that you guys pick, or if there's more patients that need that decision aid, kind of expand on adding those patients to receiving the decision aid. Questions?
It's so straightforward, right?
I have a question. Yeah. Sorry. So, definition of a chronic condition, we do behavioral health, right? We could say our chronic conditions are strictly behavioral health. But I think the goal is to move further into a bidirectional construct. We still get credit for choosing schizophrenia as a chronic condition under this model. Okay. Right.
And it would behoove you to already build off of what you've already implemented for your other reporting. So if you're choosing at your highest risk to already manage those patients, then why not have this schizophrenia to that patient?
Sure.
Than just reporting one.
Yeah, but an argument could be made that that's really not very bidirectional. It's not stepping into the medical world.
Right. The whole purpose of bidirectional is to take into consideration that.
I think.
Sorry. The whole purpose of bidirectional is to take into consideration people that have severe persistent mental illness also have chronic conditions, diabetes, asthma, COPD. So the whole purpose here is to integrate those two components together, whether it's from a behavioral health agency or whether it comes from a federally qualified healthcare center.
And identifying those populations at highest risk for one person.
All right, milestone 5 is all about quality improvement. So your practice will implement a transformation project quality improvement team to implement transformation work. Basically, this is saying that you'll have a team that primarily works with us. It should be composed of some senior leadership, ideally CEOs, COOs. That would be great to get that engaged leadership piece, which is one of the PCMH standards. And then people who do the work. So if you have like an MA supervisor, an EHR super user, a nurse, just somebody on that team. And for I think everybody here, when we come out to do the PCMHA, y'all have already created that, and those are the people who we meet with anyway. So mostly everyone who we've met with has met this standard. So
in the portal when this shows up, it'll simply be an attestation. Yes, we have a QI team. Yes. No, we do not. Check the appropriate box. And this is by sign off, so.
By sign. Barbara has a question.
Oh,
okay.
Thank you for that. So the next one, a systematic approach to using data about your practice to drive quality improvement. You will begin to work towards metrics related to the project areas and metrics related to the success of value-based payment. So if you, look across the clinical quality metrics for the project as identified by your organization in Appendix B. So basically what we're asking for this one is to pick some metrics, and like Sam kind of alluded to before, it would behoove you to pick metrics that you're already working on, that you already have statistics for. And so we're really trying not to be cumbersome, we're trying not to be burdensome, what we're asking of y'all. We're trying to say, if you look at diabetic A1C once a week, take A1C. That's what we're saying.
So that list that's in the appendix and which will be part of the portal or the workbook, those are our pay-for-performance measures. And in 2019, this year, we are now starting to become accountable for performance across those measures. Healthcare Authority will be reporting back across that entire suite, which includes access, prevention, some of it ties to hospital utilization, behavioral health, chemical dependency, et cetera. We become responsible this year, 25% of what we get relates to how well we do with that in terms of our ability to improve. Whether the benchmark comes from NCQA or it's some sort of improvement over your current performance. This year it's 25%, next year it's 50%, the year after that it's 75%. And the remainder of how we get paid is tied to pay for reporting, which includes what we call the SARS, the semi-annual report, which actually this month there's one due at the end of the month, as there will be at the end of July.
And then the last one, 583, quality improvement, practice transformation implementation work plan. I think everybody in here knows what that is. It's what we come and read to you and get your feedback on.
Hello. Hi, this is Rosetta here in CHCW, and I just wanted to go back to what was just being said about the measures at 25, 50, and 75. For point of clarification, was that to say that in the first year we have to have a 25% improvement or reach the 25 percentile? Or can you just elaborate on your 25, 50, and 75, please?
Okay, so in terms of how the ACH, the Greater Columbia, gets reimbursed, how money is accrued to us through Healthcare Authority, it's based on the overall region, not any particular provider organization, but the ACH at large, how we perform with all the Medicaid members, which are about 255,000 within our region. Yes, can you pull up this slide deck? So you scroll down. Keep going, right there. So can you see this on the phone?
I can.
Okay. So as you can see here, as I talked about year one, 2017, this was all based on certification phase 1, certification phase 2, our project plan. Last year, this was related to the semi-annual report and our implementation plan. This year, this is tied to SARS. That blue section on the top there for year 3, which is 2019, relates to those measures. We're calling them clinical quality metrics in the toolkit and in potentially the portal or the workbook. But really those are pay-for-performance measures that are assigned to us by the state of Washington through Healthcare Authority. We don't get to choose those measures, they're chosen for us.
Right, so the 25, 50, and 75 refers to the amount of monies that are the percentage of the pot that is tied to achieving those metrics. It's not a 25, 50, or 75 per se benchmark of percentile or percent improvement.
No, and when you call the pot, that's the money that's accrued to the Greater Columbia that we push up through the financial executive portal to the organizations.
Perfect. Okay, thank you.
I'm pretty sure you don't want to just stay up here. Sorry. Okay, so if you go back to 583, it reads on the terms and conditions, actively engage with the practice transformation navigator to implement and update document throughout the demonstration. When we say document, we're referring to the PTIW. So basically this is saying that you work with myself or our team and that you're nice to us. No, you don't have to be nice, we just encourage it. Chocolate, yeah. So that's it.
And for this one, the reporting is just application. Yes, we have a PKW. No, we don't have a PKW. And this one's a given because almost all of you have one except for one.
Yeah.
Have one. So this is an easy one. 6A1, care coordination across the medical neighborhood. A systematic coordination of care across the medical neighborhood. Practice will take a more systematic approach to And the reporting method, there's selection, data, and then there's a spot for a narrative as well. And then so if you look at A, ED care, quarters 1 to 4, you will implement EDI, Emergency Department Information Exchange, and actively engage with pre-managed to track discharge data. In quarters 3 to 4, you will report tracking data on patients that had follow-up contact within 1 week. Option B, follow-up on hospitalization, implement EDI, and actively engage with pre-managed to identify patient hospitalizations and obtain discharge information in quarters 3 and 4. Report on those receiving hospital follow-up contact within 72 hours of discharge. Minimum 75% of patients that are discharged need to be, if you guys go with B, would need to be contacted within 72 hours of discharge. Option C, enact care compacts / collaborative agreements with at least 2 groups of high referral specialists in different specialties to improve transitions of care, including primary care to cardiology, gastroenterology, orthopedics, and subacute services, for example, a skilled nursing facility. And this can be done in a form of MOU or other agreements with the different organizations that you guys might already have a good relationship with, but there's no formal agreement, so that can be an easy one for you guys as well. Yeah.
So what about for A1, the primary care site, and you also have interest in systems, if you have gastroenterology and/or orthopedics, et cetera. Is that a given, or do you expect something else?
A given.
Okay.
We would like to, if you contract with us again, then we would definitely ask you to build on that. But definitely in the first year is just to make sure that infrastructure and foundational information is coming through, that we either A, have the ability to do these milestones, or B, are working to implement these milestones.
Just a reminder, we can't hear all the conversation in the room, and we have a question after Rhonda.
So on B of 6A1, on the use of EDI and pre-manage, it says that we're reporting on the hospital follow-ups, and it says the minimum of 75%. Is our payment contingent on being able to report on 75%, or the actual follow-up of 75%?
The follow-up.
Wow. Okay. Thank you.
And I have another question on the C portion of 6A1, when it talks about collaborative agreements with specialists. Would dental be considered an appropriate specialist in that section as well?
Yes, and so in the toolkit, we have a full list of what a specialist could be. I know we had a question in the room from Kendra. Does substance use count as a specialist? And it does. So those 3 things that you see, right, are for cardiology, gastro, ortho, and subacute. Those are just examples of places. If you have somebody who you refer to for X-ray or things like that, like that's something that you could list as a person to have an MOU with, or an organization to have an MOU with. Does that make sense?
Yeah, case management.
Yes, that would work, Carol. Case management would work as well.
Yes.
Yes.
So for case management, if an organization had a contract with Consistent Care, Signal Health, another care management, case management organization, that's how that would unfold. So they would have to have a contract with that organization.
All right, so there's no more questions on 6. We're going to move on to 7, which is learning collaborative /training/mentoring. And I know Sam's going to go over this in detail. We actually have a curriculum for learning collaboratives that we want to go over and get some feedback on. But basically it's saying that you participate. So if you go over to the terms and conditions, in quarter 4, your practice will attest to having participated in at least 1 learning session /webinar per month. B, attended at least 4 leadership council meetings. For those of you who don't know, the Greater Columbia ACH, we put on leadership councils once a month, and they're in the Pasco area, and you do have the ability to call in. and C, attended at least 4 learning collaboratives with at least 1 provider present. So congratulations to everybody who's here. This is one.
And again, when it says a provider, right, that means an organization. Doesn't mean a healthcare professional.
Correct.
Okay, great.
And if we go, any other questions for this milestone? And then we'll go to 8A1. This is self-information technology, and this is a given as well for you guys. Developing framework for optimal use of your electronic health record in the care of your patients, meeting metrics and use IT dollars to invest in resources are necessary. And this is quarter 1, and the reporting method is just a selection. And in the first quarter, your practice will work with the practice transformation navigator to identify infrastructure, resources, etc., that will be required for the period of the Medicaid transformation project. And this is when we have our kickoff meetings, and we consider the PCMH assessment, rehab for those that have behavioral health integrated. That's where we, for this one, we check it off.
So for those of you who have the toolkit in front of you, I think on milestone 8, it just simply asks for an attestation that says that you have an ONC certified EHR. So everybody has a certified EHR. So like Martine said, it's a gimme.
And that's part of a requirement for meeting coordinators as well.
That's it, guys.
Questions? More questions? All right.
Thank you.
Can we go back to the Exhibit A, and just so that they can look at Exhibit D and Exhibit A together? Happy New Year! And it's my birthday today. Hi, I'm Sam Riddell. Happy birthday to you. Happy birthday to you. Thank you. Thank you. I'd like to briefly touch on looking at Exhibit D in comparison to a crosswalk for your Exhibit A1. For 1A1, your proposed budget, and of course, that was also a valued or a weighted system. I just want to make sure that we understand that if you're looking at a value system of 1 to 3, that if you only do a portion of your budget and the dollars don't match, then your practice navigators are there to work with you. It's not a do or die situation. They're going to come back and they're going to try to reevaluate and see where they can associate those dollars and work with you on those to make sure that you're going to meet each one of those milestones. In addition to that, I don't want you to think that you have to do every single milestone. It's not an all or nothing. So just to make sure that you understand that we encourage you to do every single milestone, but if your system just cannot or you feasibly cannot do care management, then that doesn't mean that you're not allotted to finish all the other milestones, okay? And that's, I just wanted to briefly, is there any questions on how that might look? So if you only associated $10,000 and practice navigators kept going back and back and back, and they're like, we really need to get this budget done, then you might only get like a 1% value on that, those dollars.
If the budget take into consideration just these dollars, or does it also include the base population of $5,
Yes, and it goes into great detail on the toolkit. So down at the bottom here, for this particular clinic, the base population health funds is $70,000. So anything that is included, with the exception of the PCMHA and the MEHAP and the QI team, should be included on your budget. But the toolkit explicitly tells you what to leave in and what to not.
No question. So you're allocating dollars straight across that quarter, and it's a progressive process for us to establish it. So if we are highly successful in the second quarter, but not so good in the first quarter, do you adjust the dollar amounts, or is it we've lost a portion of the 3650?
It's based upon the milestone reporting, and the toolkit goes into detail on what that looks like. And a lot of trainings is a selection, and then in the first quarter you're doing a selection. The second quarter may be, are we working towards it? A third quarter might be, give us some data. Where are you on this process? And then the fourth quarter would be, have you implemented this? So that's just an example of how that might
Sure,
look.
sure. But in general, on all of these pieces where there's dollars across all 4 quarters, are we losing out on opportunity for that funding if we make up for it later on in the second, third quarter? We could still acquire all of the funding, the 48, for example, 48,660. We could still get to that if we move along.
Continuously work on it, work with your practice navigator to identify issues or concerns or infrastructure that needs to be in place for that particular measure.
Right.
Definitely. The idea is really to give all the funding out to all the organizations and employers to be successful at each milestone. So not really be punitive or prescriptive at all. No. Any questions on it?
Yeah, where would unclaimed dollars go? I mean, what happens there? So, somebody doesn't make any quarter of, the milestone. So, who's originating?
Carol will actually.
So, the dollars reside with financial executor. Yeah. We don't have any of the money. We don't, it's not in our bank account. The only way that it is released is when we tell the financial executor, hey, Lord, $291,000. And then they will do that. So if you don't earn that funding, then it just resides with the financial executor, and then we just carry that forward for next year's.
We're going to go on vacation with it. Carol, can you also go ahead and add right now about the charter? It's not solely my decision based upon what money is going to be allocated based upon your evaluation of whatever you report on the milestone. Can you talk about the charter and how the practice transformation project team will be involved in that?
Yeah, so every quarter after we report, you can see all the things that are reported on a quarterly basis. And the practice transformation work group kicks into its next phase of work, which is to look at those evaluations and say, do we need to adjust something? Does this make sense on what we're asking our providers to do? Do we need to add more clinical quality measures to get them more up to speed? So based on what our practice transformation work group evaluates, and how well we're doing, that might have influence on how those dollars are spent. One thing I can say is right now, we know that there's a second wave of integrated managed care funding coming. So the first year was $4 million, the second year is the second at $6 million, and our board of directors will be looking at how we're spending those funds. We'd like to associate them more with the opioid use crisis, however, so we're looking at ways to form perhaps a learning collaborative around opioid use. So that's one thing that we'll be looking at.
This is our training curriculum that we were, a proposed training curriculum based upon each one of the milestones. Really want to look at this today just to kind of get an idea of what was alluded to in our CSA, but also to make sure that we're meeting each one of the milestones and getting the training that for each one. CSA is current state of assessment. It's a evaluation form that each of you probably drank to. Isn't that right, Rhonda? So if we can kind of go through this briefly, there is other categories that are included in this. It's, the dates, the time allotment, who should attend, what type of learning, trainers, purpose, and outcome, and then resources and additional training to reference in the CSA. I want to take some notes while we're talking about this. I want it to be a discussion. So of course today we had to kick off in a contract and milestone review. And then who should attend is the accounting personnel. Resources would be the sample budget, and actual budget contained in the toolkit, and additional training to reference. So if we go down to the next one here, 5A. So 5A1, this is everything that we covered today. And then there's additional some information on, so right here, 5A3, how to drive value-based reimbursement. And those are additional trainings that we could look at and to incorporate into additional curriculums if that is something that everybody is interested in. But that was what was actually stated into the CSA as one of the higher opportunities for learning for each entity.
And you might just preface by saying, this curriculum is based on the deliverables that we just reviewed. So all of the milestones that we're asking you to report on, we're giving you training on how to do empowerment. And this is the nice thing about these learning collaboratives is that you will be learning from each other. So when Bill Dunleavy says, our experience of having a patient family advisory council at the clinic level was far greater than having a overall system-wide feedback. And then Barbara can say, well, we had this experience with Kevin, so that you come together and you learn from each other. Or empowerment, how did you guys do that? Why is Yakima Valley Farm Workers so good at this? What is it that they're doing that enables them to have that high-level achievement in empowerment? So these are meant to be learning opportunities for you to learn from your peers.
I do want to make sure everybody is aware, our next one for our meeting for the budget, if we can go down to all of past this date, that'll be the next one. So 2/7/2019, we are going to schedule for our first learning curriculum, which would be an interactive budget. So if you don't understand your budget, it's a great opportunity for everybody to come together and you could possibly complete your budget that day. So please don't stress about the different milestones. We're going to have a lot of learning collaboratives based around each one of the milestones and making sure that you meet those measures, as well as your practice navigators are right there in your organizations or available by phone if you need any kind of questions that need to be answered immediately. So we want to make sure, again, that everybody's successful at meeting those milestones, especially the first one, because we'd like to put those payments out, right? Particularly for this overview, I would like to look at some areas of additional opportunities. I'm not sure if we should do a doodle poll or something like that, but just kind of briefly go over and we can send this out. What do you think, Carol?
For these,
For additional trainings that might be really beneficial to each milestone, and what time frame they would like to look at in.
Yeah, we'll send out the learning curriculum and we'll take your feedback on it. If there's something that you think is particularly missing in terms of the team concept, or as an exemplar organization, you guys are missing the boat by not emphasizing this section or this aspect of PCMH, then we'll take that into consideration as we're developing the learning collaborative.
And what time frames need to be involved in that? For example, if we go down to medication management, right there. So we have the PDMP, and then we have MAT training, medication-assisted treatment, alternatives in pain management, buprenorphine waiver training program. Those were identified in the CSA for training opportunities. That would be possibly an all-day training. We could do multiple different workshops within that particular milestone. Those are the feedback that we really need to be able to implement these different collaboratives. Let's do one more, and we'll talk about that. Let's go down to, let's see, one that's another big one. Exemplar clinics. So this example would be create work groups based upon the needs of, go down just a little bit, I can't read it. The needs of the organization. So the exemplar clinics that were identified, this is also one of the milestones that's identified in the, for the exemplar clinics as far as training and collaboratives and those sorts of things, that they need to be able to look at creating work groups based upon the needs for this particular date, which is November the 14th, 2019. One of the ideas or one of the agenda items that was in the CSA that was stated that people want to know about residency programs, and I know that we have a lot of residency programs within those exemplar clinics, so we thought maybe that would be a topic of conversation during that particular one. Success stories, lessons learned, it's also in your toolkit. Each person or each entity will do a story related towards the end of the series or demonstration. And so if you guys have any feedback on what that might look like or what the formatting might look like, but we would like to put it in our brochure or our newsletter, right, Carol? We would like to have more than just one. We would really like to highlight every organization that achieves a milestone every quarter. So, any questions on this? And Lauren, you'll send this out, and then we can just get some kind of feedback, and we'll make it a little bit more concise on what feedback that we need, and kind of get an idea of the questions that we're looking at. Okay. All right, thank you, guys.
So we are ahead of schedule, which is always a good thing. So Sam talked about the learning collaborative. So does everybody understand that the learning collaborative really is just that opportunity to extend your learning beyond what you might already know? And we are taking the model from the IHI Breakthrough Series that has shown that when you're a part of a team to learn things together, you make changes faster. You're able to implement changes within your practices more quickly and more successfully. So the Healthcare Authority is really driving and pushing some type of learning or quality improvement. So we will be graded in July in terms of what our quality improvement strategy is. And this is part of our quality improvement strategy, is to find these learning collaboratives. North Central has already started their learning collaboratives. They're doing weekly sprints. So you should take it, but you don't have to spend an hour every week doing a sprint. We're trying to make this as least burdensome as possible. So one of the requirements is if you attend any kind of a monthly webinar on your own within your practice, you can get credit for that, because we all know how many webinars there are out in the universe. So it's just up to you to be honorable and report honestly on your activities. We did hear Sam alluded a little bit about the current state assessment and some of the learning opportunities that we heard about. Yesterday, Wes and Diane and I met. Diane's our new project manager for our opioid crisis project, and we realized that there's so many opportunities for provider training in this arena, as that we will probably start an opioid learning collaborative, right, Wes? Because there are just there were requests for buprenorphine waiver program training, informal relationships, informal referral relationships with providers, protocol for patients and clients when they relapse. What was the theory of behavioral change?
Pre-contemplative to contemplative, and motivational interviewing.
Yeah.
There's a model stages of change. For those who are in behavioral health, you know exactly what we're talking about. Sure.
So these are the kinds of things we'd like to hear back from you, is if you have particular wants or desires, even getting in people to talk, national speakers that you might know of that can come and do some of this training on, for you would be welcome. Yes, Barb?
Well, I think we're talking about a series of 3 webinars on opioids, January, February, and March.
Excellent.
Yeah.
So stay tuned and give us your feedback, and we'll try to accommodate your requests through these learning collaboratives. Finally, the toolkit. How many of you actually thumbed through the toolkit? Some of you did. It was meaty. And we know that, and so that's why when we met with Meet yesterday, and he said, as a medical provider, I can tell you that this is quite onerous. And we're like, okay, so what can you do to help us reduce that onerousness, So we are working with a physician who is also a software developer to try to, to reduce the burdensome reporting requirements and take his lead on that. And he's working with a team of people, so we can't guarantee how soon that's going to get out or it's going to get finalized, but we are working like crazy to try to get that toolkit, that platform ready by March 31st, when your first reporting requirements are due.
With the exception of the budget, which is due in February.
Yeah. And there was one question about, well, how soon do we have to meet those reporting requirements? I can tell you that because of our reporting schedule, we have to report everything every 6 months. So our next report is due the end of January for the last 6 months of 2018. Our next reporting requirement will be due the end of July for the first 6 months of this year. So we will have to have your reports in by June, probably, you know, at least July 1st, so that we can fill out all of the reporting requirements that we have from our end. I can say that we've done very, very well in receiving funding. We've hit 100% of our monetary allocations through our reporting system. So we have a pretty good team that's working like crazy to get you guys as much money as we can. Yes, Rick.
So earlier on, you said we weren't going to go into great detail on the toolkit itself because you got editing to do. I think one of the things that happened as a result of having our presentation on the measures compared to the toolkit is the toolkit is very prescriptive in the way it's written. And, you know, Martine indicated that it wasn't so much. There's more flexibility in it. And I would encourage in the language of that to focus on the measure and let us know around the varieties of ways that we can get to that measure in a way that's different than the way it's currently written. And are you going to be receiving additional feedback? Can we give you additional feedback on some specific parts of it?
We did. We sent out the toolkit to a few providers, and we had the practice transformation work group take a look at it, but we would welcome any specific feedback that you have on that, because we're still trying to make it a very useful tool, but we don't want it to be so unuseful that providers prefer not to be a part of the program. You know, we're all just trying to work towards BBP and helping you get better practices put together, trying to urge that bidirectional integration because we know the best outcome for the patient. We're not the experts, you guys are, and so we would take your lead in giving us some suggestions on.
I mean, I think it's very helpful, and I appreciated it. But again, I thought it's more prescriptively written than it was talked about today.
And it's only intended to be a guide, and I think that that's where the terminology gets lost. It's a guide, and what the deliverables is really in the summary itself.
Yeah.
And then being able to answer those questions that are reporting that apply to that summary, so for this terms and conditions. So does that kind of help a little bit?
It does. Yeah. So.
I'd add to that this version is much improved on that one. Like it was just much clearer.
We're working on it. Every iteration it becomes a little bit clearer, I think. Yes, Barb?
Carol, but I hear Sam say that the next legislative is interactive budget training on the 7th of February. Is that in place of the Pakistan work group then?
I'm glad you mentioned that. The PTW will only meet quarterly now because of all of these other requirements that you have on your plate. So, and that will only be after we get back the majority of the reports from the providers, because that's what you guys will be looking at. We'll be bringing you the results of the reporting from the provider organizations, so we can say, what are we learning from this? You know, how much more work should we be doing? So there has to be that monitoring and evaluation by the PTW. So we will send out a new plan. Is that okay, PTW members? I didn't hear anybody go, oh. Lily, was that your same question, Lily?
No.
Oh.
Well, I was just understanding, I think part of the committee and the toolkit is because many different kinds of people are going to access it, many different kinds of circumstances, and as granular and detailed as the GCACH can make it is going to help answer questions, remove people from, or, you know, raise the need for people to call in, this or that, and just trying to utilize it. But maybe if there is a quick conference or something, a way of building some of that granularity in part of the toolkit, so people rush to, you know, use it on a more frequent basis to kind of go there with some people like read through paragraph after paragraph of information. And I think that might be a good thing for us to look at too. But you know, I don't have to use it. I don't have to find it burdensome or not, or answer that question. But I think if you can go to a point where you tip over into not enough information in that document, so that people have more questions, and you know, spend more time trying to figure things out. We don't want.
And we don't want you to do that. So that's why you have your personal toolkit called Jenna and Martine.
Yes. And Exhibit C
Jenna and Martine are actually going to update these for clinic or organization to reflect what you chose within that toolkit. So you have a quick reference guide to know what your deliverables are and when they're due. In addition to that, they're doing the PTAW, it's a living document, and that serves as one of your milestones, as well as that you're referencing what your goals and how you're achieving those goals.
A little bit about the reporting piece when it comes out in the platform or the portal. The information that you enter in the first quarter, we want that to populate through the entire year. So if you go back into the portal in Q2 to do your update, you've already answered all the questions or 80 to 90% of the questions. You want to equip the portal so those answers are already there. So there may be a big lift this first time around, but going forward, there should just be update. For example, tables that have numbers or numerators and denominators, those will need to be updated, but where you're making selections among choices or within tables, those should carry through.
Yes, my question was related to 381 to 481. No, 481 and 42. Patient interactions and patients, I mean, both of them are related to the importance of providing care based on the patient needs and healthcare position. And I was wondering if under this category, cultural competency, like cultural awareness, continuing education, can hold huge needs of bilingual, bicultural services. And even though I have seen bilingual staff, even bilingual providers, I think they are not going to get huge needs. And even when we go to practice, basically, sometimes we can be bad recruits that people for the private education that we serve because we don't have the appropriate recruiting tools, and it's easy to recruit people that sometimes do not belong to the private education, and I think that's very we serve not only Latinos, not only Caucasians, but we serve Native Americans, and we have other ethnicities that are coming, that are migrating. And so having the appropriate tools to reinforce and make sure that what we are really saying we are doing, we really are doing. I mean, we really are seeing that improvement because behind the lack of cultural awareness and bilingual ability to serve the patient and to seek for healthcare is a fear. So patients will not complain. Patients will not demand. So patients they will see a non-strength. And I think that's we made sure that it's part of our milestone and part of our options when you look at the toolkit, we do cover cultural sensitivity.
Milestone 4.
So that we did cover that. Any other questions? Any questions from the phone? Well, I would like to thank everybody for attending your first Learning Collaborative. You all get a star for today. And thank you, and we will see you soon. We will let you know the case of the rest of the Learning Collaborative. We'll send out a doodle poll. You guys can fill out, your suggestions for Learning Collaborative material like Chloe just suggested, and then we will see you in February. Thank you.